While we're waiting for people to get started, I'll do a little bit of the background of this and then we'll get going. So welcome to the JHWiki Partnership for Excellence in HIV Care across Central Maryland's webinar toolkit series. And for those of you who don't know JHWiki, our vision here is to achieve a more coordinated response to HIV care, really by thinking about and establishing beneficial relationships that increase the quality of care to the communities we serve, which are women, infants, children, and youth. This is a Part D initiative under the HRSA's Ryan White funding. And really, this toolkit was established to engage all of you, to build upon the existing structures and systems, to think about and create a dedicated network of wiki providers to coordinate across multidisciplinary systems of care. While I am here talking to you, Dr. Renata Arrington Sanders is presenting, but the idea is that we all have something to share and ideas to engage and to amplify our voices and experiences. Next slide. Today, it is my distinct pleasure to present my friend and colleague, Dr. Renata Arrington Sanders. And before she gets to get going, I get to embarrass her with all kinds of amazing things. So Renata Arrington Sanders, Associate Professor in Pediatrics in the Division of Adolescent and Young Adult Medicine.
Hey, Allison.
Yes.
Can I stop you for 1 second? I'm having a hard time hearing you clearly.
Are you?
Yeah.
Let me see. Let me turn that up. How's that?
Everyone else is having the same issue.
Can you hear me now?
Yes.
Okay. I think my volume was low.
Okay.
So I'll go again. So I was saying today, it was my pleasure to introduce my friend and colleague, Dr. Renata Arrington Sanders. And she's an associate professor in pediatrics in the Division of Adolescent and Young Adult Medicine and co-directs the Pediatric Adolescent HIV/AIDS program here and the Emerge Clinic, which is our clinic for gender-affirming care for young people. But a little bit about Renata, undergraduate at Johns Hopkins and did her medical school at University of Virginia, residency at University of Cincinnati and Cincinnati Children's, and that residency was in Med-Peds, or internal medicine and pediatrics. She just followed up and did a fellowship in adolescent medicine here at Hopkins. And then, because that wasn't enough, did a NPH at SCM, or Master in Science, at the Johns Hopkins Bloomberg School of Public Health. Renata's clinical focus is sexual health and HIV care outcomes among adolescents and young adults. And she has many areas of interest, but really is nationally renowned for HIV STI prevention, testing, and PrEP, and really thinking about expanding clinical services for sexual, gender, and minority youth of color. She's really a paradigm changer, not just clinical operations, PrEP, the Emerge team, cultural competency among staff, LGBTQ staff force, medical records, community cred to the max, and has diverse support from local, Baltimore City Health Department, federal, the CDC, and NIDA. But I think one of the things I'm so proud of Renata about is her advocacy and addressing disparities in testing, sexual health, and access at, again, local, national, and then international level. So it is my true pleasure to introduce my friend and colleague, Renata Arrington Sanders.
Thank you, Allison. Oh man, I should get you to introduce me more often. That was amazing.
Thank you.
Can you hear me?
I hear you great.
Marina's, am I good? Okay, great. I'll go ahead and share my screen. And I hope that this really, I hope I have a chance to do justice to this very critical topic, because this is a community that I'm passionate about, that I know many of you are passionate about. And so I think I want to spend some time, hopefully, just talking about how we can really optimize the care of the LGBT plus community, particularly youth that we serve who are at risk or living with HIV. I have no financial disclosures. LGBT plus youth experience higher rates of substance use, sexually transmitted infections, bullying, rejection, mental health challenges, including suicide, self-harm, than their heterosexual and cisgender peers. And so today, I want to talk about some of the key aspects of adolescent development and how they may be different for these youth particularly their key vulnerabilities and contextual experiences that they may experience, as well as summarize some of the evidence-based methods, particularly a strategy that I use when addressing these vulnerabilities in clinical settings that I hope that you may be able to take with you at the end of this talk. Let's start out by defining who youth are around the world. Youth are defined differently, right? So as children, adolescents, and we're really going to focus on this blue line here, whereas really focusing on youth that are 10 years to 24 years old. So what is adolescence? Adolescence really marks that transition from childhood to adulthood. There are three key areas of adolescence and where adolescents develop cognitively, psychosocially, and emotionally. And cognitively, adolescents start to have advanced reasoning and start to think abstractly. Psychosocially, they're really trying to identify and formulate their identity formation, really figure out who they are as an individual from an identity perspective. And emotionally, really being able to regulate their own emotions. Unfortunately, on the other end, we also see that the brain develops. The brain controls all those executive functions, those things that help us not to have that impulse, that quick response. This is the last to develop during adolescence. And so while all this great cognitive, emotional, and psychosocial stuff is going on, those executive functions may actually occur a little bit later. And this is important because it really explains the nuances within experiences that adolescents have. The stages of adolescent development start with early adolescence at age 10. And so this is the timing of puberty. Gender identity formation may occur or formulate, and youth really start to think concretely. So really A plus B equals C. Can't be D, can't be X, can't be Y. It has to be D. And so this is when youth may actually start to talk about or articulate that they have gender dysphoria. Why does this occur? Because puberty is a reminder, a physical reminder that your body may not reflect your gender identity. And so we often see youth that may identify as gender diverse or transgender actually coming out as gay or bisexual because they're trying to test the waters. Self-exploration is really normal during this stage of adolescence, but there are also a lot of anxieties. They're also looking at their peers. Why does my peer look like that? Why do I look like this? Am I normal? These are all normal questions. There's limited dating and intimacy. So if you see an adolescent at a young age, in this age range, that has already started to engage in sex or sexual activity, that should be a red flag. Let's talk about gender identity. So gender is a socially derived concept. It's really based on gender roles, expectations from society about behaviors and characteristics and thoughts that go along with the sex assigned at birth. It often reflects sex assigned at birth, but it may not, right? So it may not align. Sex assigned at birth is assigned based on external genitalia at birth. So a physician or provider or nurse looks at the external genitalia and says, congratulations, you have a boy. Congratulations, you have a girl. So that's based on those external genitalia. Gender identity is different. Gender identity is really personally and culturally defined. It's a construct as one's sense of maleness or femaleness or otherness or non-binariness, right? Or fluid. So it's a sense of self. It does not equal sexual orientation. So I hear this all the time. And what I talked about at the beginning of youth actually testing the waters, that's different from individuals saying, oh, I knew they were trans because they were gay, right? Two different constructs. We're going to go through what sexual orientation is next. transgender relates to an incongruence between the assigned gender at birth and one's gender identity. And so I love this picture because while this individual may have been assigned female sex at birth, when they look in the mirror, they see their true authentic self, which is a male. And so what we know from terminology is that transgender female individuals often identify as female and are assigned male sex at birth. Transgender males assigned female sex at birth, identifying as male. And then there are individuals that may be non-binary or non-congruent or fluid that identify as neither or both or fluid. Cisgender refers to the congruence between gender at birth and identity. And so after the first stage of adolescence comes the middle part of adolescence. And this is where adolescents start to weigh risks and perceive implications of those risks. They may not apply it, but they can perceive it. But this is also where their emotional reward center actually lights up. At the same time, they're sorting through sexuality and sexual orientation. And so they might start to experiment in sexual behavior. And so sexual orientation really has three dimensions. It includes attraction, sexual behavior, as well as sexual identity. And so sexual identity speaks to your identity and your affiliation with that larger social group. And so who you see yourself as. And so those three components make up sexual orientation. And I like to show this as the three interrelated circles because they don't always align. They may overlap, but they don't align. And that's completely normal. During late adolescence, we see that youth start to establish more secure relationships. They think about things for the future. They start to have long-term relationships and intimacy. And so they start to secure or be able to even think further beyond their identity. But there are key vulnerabilities that youth experience during this time, particularly for LGBT plus youth. Not only the developmental stage, but trying to navigate minority stress, lack of employment, lack of housing, substance use, racism and stigma are all critical contextual experiences that youth experience. So let's look at these. Starting with mental health, 50% of all adult mental health diagnoses occur before the age of 18. So adolescence is that critical period where a lot of youth who are going to have a mental health condition in adulthood experience them during adolescence. Gender and sexual minority youth and youth living with HIV are at greater risk for mental health problems because of these coexisting conditions that may actually preclude them to high rates of mental health. Particularly for LGBTQ youth, we see that they experience high levels of stress, anxiety, which is much greater than their cisgender peers or heterosexual peers, as shown here. I love this quote. And so they often describe fear that keeps them from engaging in services. Bullying and victimization is another key area that a lot of LGBT plus youth experience. 1 out of every 5 high school students reports having been bullied in school. And 1 out of 5 9 to 12-year-olds report having been cyberbullying. So remembering that it's not just in the school, in the physical space, but also online. And forms can occur as physical, social, and verbal harassment. Students who experience bullying are often more likely to present with depression, anxiety, and sleep difficulties, and are 2 times more likely to report having headaches or stomach aches. And nearly 9 in every 10 LGBT plus students have been victimized at school. So if you're seeing someone who is an LGBT youth, they likely have experienced bullying and victimization. What we see here is that this is data from the GLSEN 2017 and 2019 climate survey that really sexual orientation and gender expression are real occurrences of not feeling safe at school, and commonly occur among the population that we see. And what results is frequent missed days of school. So if you're seeing someone that actually is missing a lot of school, this is a red flag to ask about bullying. Particularly when bullying and mental health can intersect, it can actually result in a really hard outcome. And this is a Nigel Shelby, and I don't know if you're familiar, but he passed in 2019. And this quote was from his mother. When you have a kid that's already depressed and going through a lot emotionally, for you to call him names that you shouldn't call them or say stuff to them, it sometimes has a worse effect than it would on a child who's not struggling with depression. So that intersection between bullying and mental health can be critical in this population. There's often family unacceptance that also contributes to adverse mental health. Sexual minority youth and gender minority youth report family rejection during adolescence more commonly than their cisgender and heterosexual peers. And they're at increased risk of poor mental health outcomes, increased risk of sexual risk behavior as a result of it. And so this quote comes from the HRC's youth report. I'm not out to my parents for safety reasons. If they found out I was gay, they would kick me out or force me into conversion therapy. A lot of youth experience this. And it leads to unsafe housing and lack of employment. So LGBT plus youth account for 40% of the homeless youth population. And in the PUSH study that focused on sexual minority men and transgender women that were 15 to 24 years old, we found that 25% of those youth described not having had a place to stay, a regular place to stay in the prior 12 months, and engaging in transactional sex. That's high for this population, high. So not having a safe home environment leads to this potential behavior. I do want to mention conversion therapy or change efforts, because a number of youth actually experience conversion therapy. And conversion therapy is described as a range of techniques used by a variety of mental health professionals and non-professionals with the goal of changing sexual orientation or gender identity or any of its parts. And so the newer term is around change efforts, because we know that this is not therapy, okay? So it is not good. So we're trying to take away that word therapy because really focusing on how these change efforts are harmful. And when asked in a large representative survey, 7% of lesbian, gay, and bisexual persons and 14% of transgender and gender diverse persons described having experienced these techniques. These techniques have been associated with decreased self-esteem, self-image, quality of life, and increased substance use and suicidality and suicide attempts. And so really, as many as over 500,000 of adults have received this therapy, of which 3/4 of them experienced it during their childhood or adolescence. So as we're taking care of youth, we have to start also asking about these experiences. The context of substance use is often common as a result of adverse mental health, suicide, depression, anxiety, and most common substances are alcohol, marijuana, and tobacco, but we find that other substances do also occur. By 12th grade, 2/3 of students have tried alcohol, and about 50% of 9th through 12th grade students report using marijuana. 4 in 10 9th through 12th graders report using cigarettes, and 2 out of 10 report using prescription medicine without a prescription. And substance use can lead to unprotected sex or condomless intercourse, dangerous driving or driving while intoxicated, sleep disturbance, memory loss, and poor school performance. We found in the PUSH study that 79% of participants described polysubstance, including alcohol, marijuana, and other drugs, which included cocaine, methamphetamine, and heroin. Sexual debut is also another critical area. As shown in this slide, by the 12th grade, 56% of adolescents have engaged in sex. This slide to the right shows this broken down by sexual orientation and sex of the sexual partner, demonstrating that almost 50% of gay, lesbian, or bisexual students have described engaging in sex during high school, which is higher than their heterosexual peers. I mentioned early sexual debut or first sex, and what we see is that fortunately, most, when you look at the overall average of students who engage in sex before the age of 13, most describe very low rates of sexual activity before the age of 13. However, among African-American, self-identified African-American students, as well as among gay, bisexual students, what we see is that the rates are much higher. And when asked about sexual behavior, the percentage actually increases up to as much as 12%. This certainly is an indicator of risk. Early sexual debut before 16 has been associated with increased HIV risk. And some studies have estimated that 61% of young MSM and adult MSM report sexual debut before the age of 15 years old. We do know that lower age of sexual debut has been associated with transactional or survival sex in transgender youth, and younger age at first sex can result in risk, mostly because of the biological vulnerability that exists in these youth, but also because the intersection of that with the inability to negotiate condoms, often with an older partner, and the propensity that sometimes older partners may have HIV. So our focus is really centered around addressing HIV, preventing HIV in youth. In 2018, there were over 37,000 new HIV infections. 2 in every 10 were among youth, 13 to 24 years old. 9 out of 10 were among young men, and 5 out of 10 were among young, gay, bisexual men. And so we really seek to get people tested and then into or on prevention, or if they're living with HIV, undetectable, because undetectable means untransmittable. But there are multiple barriers to actually get to that point. So I want to spend the next part of my talk really talking about interventions and evidence-based methods that can address these key vulnerabilities in clinical care. I like to use a socio-ecological approach to address these vulnerabilities that I've talked about. The socio-ecological approach is a benefit because it addresses factors both at the personal, the social, the structural, and the policy level. At the personal level, there's often intersecting identities, there's perception of risk, efficacy around condom use that may impact one's ability to engage in care or prevent HIV or engage in treatment. Intersectionality is this concept of the adolescent being in the center of all of the adolescent's identities, and that you can't separate them out, right? So being Black and cisgender and gay and coming from a low income neighborhood, your experiences may be very unique to all those intersecting identities and different from someone else who has different intersecting identities. And so it really talks about the strength of taking into account all of those identities. And why does this matter? Well, one of the key tasks of adolescence is identity formation, is figuring out who you are. And racial or ethnic identity, for example, is a group identity. And it actually provides a common sense of identity, of internal sense of self and self-concept. And really, it impacts how you interact with others. And what research has found is that for Black and ethnic minority youth, Latinx youth, is that it may actually be more significant than sexual orientation or affiliating with other groups. And I love this picture because this really speaks to, but mainly Black, right? So you have to take this into consideration when you're taking care of the youth we serve. So really, providers spending some time discussing individual identities and really what it means to youth is a critical step that providers can take. Second, we have to really understand people's own views on risk and vulnerability. Just because we assume one's risk or one's vulnerability, it may not matter for that individual person. I like this clip because it really demonstrates this.
We are going to get tested for HIV. And I don't want to hear any, I don't need to be tested. You're going. We need to know our stats so we can stop spreading this disease.
I want to know. And if we do it together, it'll be less scary. Don't you want to know? I'm not sure. I guess.
You coming too, right?
Oh, he doesn't need to get tested. He's not running the streets. I think I do. But you can't get it from a woman.
Listen, I prefer the ladies, but I'm an equal opportunity lover.
Ain't nothing wrong with that.
Oh, wait, if you're being safe, you shouldn't have anything to worry about, right?
Back in the day, when I was real hard up for cash, I'd let dudes suck my dick.
The symptoms are different with everybody.
So we've all seen Pose, and I love that clip because really there's an assumption about that young man's risk. Well, he can't have it because he presumably may identify as straight, right? So there's assumption often about risk based on sexual orientation or sexual identity, when we have to remove those assumptions of risk because what did I say earlier? Behavior does not always align with other aspects of identity, especially during adolescence. Also, youth may have limited health knowledge. And so we know that comprehensive health knowledge has been associated with condom use, increased voluntary testing, as well as engagement in HIV care. And so we also need to be aware of the limited health knowledge and create community messaging and messaging that can increase knowledge and raise awareness. These are two advertisements that Dr. Errol Fields has created for our clinic and our Preppers for Youth program to really engage youth from different groups, right? And to provide health information so that youth can actually see themselves in the images and know that this is a safe space. At the interpersonal level, social support, parents, providers, and partners really matter. I'm not going to focus on all these areas, but just a few. We've used a coach-based intervention in our clinic and as a clinical trial to really improve the care of Black and Latinx sexual minority males and transgender women to engage around HIV treatment and PrEP use. And so the focus is really having a coach that focuses on life skills, motivational interviewing, and reflective listening and goal setting to communicate using one-on-one interactions in a mobile app to really improve care and to provide ongoing feedback on how people are engaging in care. And so what we found was that health coaches were perceived as being very helpful in identifying and reaching goals and making you feel accepted. This is what one youth said, because they let me know that I'm not alone. There was always someone there I can talk to. We found that regular health visits were associated with having health goals, and that participants described knowing someone or having a peer in their network made them feel more likely to take PrEP. So the sum for this is really peer coaches or navigators can improve engagement and care. So finding someone who looks like the population, maybe slightly older, that can really engage in youth into care may be critical to addressing those vulnerabilities. Additionally, fostering family acceptance. So we know that family unacceptance leads to risk, but family acceptance has been associated with higher self-esteem, overall increase in general health, and protective against depression, substance abuse or substance use, and suicidality, as well as HIV and sexually transmitted infections, particularly among young men who have sex with men. And so this is from the Family Acceptance Project, where it's just a physical lanyard that can be posted to say, here's some skills, here's some ways that you can affirm and support your youth, right? You can actually support your child's gender expression. Have your child bring over LGBTQ friends. Like, we as providers can give patients and also their families concrete examples of how to support them. And then also parents do have a role. So there's some work that I've been doing with Dr. Jack Rusley just around how do we prep parents for the talk about sexuality. We can do this. If parents don't know how, we can do this. And some of his work has really found that parents can fall into two different groups, a low willingness and a high willingness group. And that parents who were low willingness were just not aware of their child, their adolescent's sexual experiences, and perceived their adolescent to be at low risk. Whereas those high willing parents that were willing to have these open conversations were expressed being open, and also specifically having had sexual health communication discussions with their adolescent and using engaging dialogue to do so. So if parents don't have the skills, providers can talk about, hey, here's an example of some language that you can use to engage in those discussions with your youth, to be able to support them in a non-judgmental way. I do want to acknowledge that while conversion or change therapy has been inappropriate, the Black church actually does provide, or the church in general does provide, an important part of support for many of our youth. 80% of Blacks report religion as an important part of their lives. And being out in, we found that being out in a prior study, actually in religious groups, was associated with increased levels of pleasure and sexual satisfaction. And so some youth do experience rejection. And so some youth do experience acceptance, and it's different for everyone in this setting. And so I think you really have to explore the role the Black church or religion, for example, may play in the lives of youth, because it may be a key source of support for the patients that you serve. At the structural level, there are many barriers to care that we can work towards addressing, including our own physical spaces. So really trying to create physical spaces. We post this lanyard that's here to the right at every check-in station, so that people know that this is an inclusive, accepting, welcoming space for everyone, regardless of sexual orientation or gender identity. And so affirming care really means that you're engaging all normal aspects of human diversity, that it's not a mental disorder, that you're not stigmatizing individuals for being gay or being bi or being trans, that you're welcoming all those individuals. And this is affirmed by the WHO, the World Health Organization, the American Academy of Pediatrics, that really providers have a role to create welcoming spaces and welcoming environments for everyone, regardless of their sexual orientation or gender identity. We also need to meet youth where they are. So we've been fortunate to recently be awarded a virtual online grant through the health department to find youth in virtual spaces and engage them in virtual testing and health navigation. And within 6 months, we had 500 users that visited this site, almost 30 LGBT plus youth were offered testing. 6 were tested virtually, meaning there was a coach on one side, and actually the camera was on, the video was on, and they were actually doing testing and counseling right there in real time. 8 were offered PrEP, and all were linked to prevention. So just getting started, and we hope to see it really, really blossom in the next year. But this is an example of how using other types of spaces to meet youth where they are is really critical and important. We have to also be aware of racism-related stress at the structural level. A lot of our youth experience racism, and 3 out of 4 of them have experienced microaggressions because of their race. And this can lead to marginalization and lower healthcare engagement. And so sometimes some of the youth, and we found this in some really nice qualitative interviews that youth described, as well as key service providers, that aspects of the clinical setting, the clinical space, can contribute to feeling marginalized. So if the wait is too long, they think it's because of them, right? People look at them funny when they come in to check in. They think it's because of them. So we have to be mindful of these other pieces that may contribute to marginalization in the clinical space that we're in. And so an intersectionality lens will allow us to really think about all those different identities and how to incorporate that into the care that we provide. We also need to think about those larger social norms and contexts that many of our youth experience. Police brutality is common among Black males, and it's the sixth leading cause of death. And particularly LGBTQ of color are often the source and the target of blame for events and victimization. So we have to prepare and have mindful conversations about what's the real life experience of youth outside of the clinical setting, and how can I prepare you so that you can get home safe, so that you can get back here safe, so that you can live a healthy and productive life. And then providing access to housing and employment is critical. Particularly, we found in the push study that having a regular job was protective against engaging in exchange or transactional sex. And the Work to Prevent program, which is a skill-based goal-setting program, has really found that economic stability through job readiness and employment can be protective against HIV as well as HIV risk. At the state level, sexual education actually varies by state. And across the state, there are 13 states that actually have variations in care around sexual education. And so using the YRBS data, we found that young men who have sex with men actually received lower receipt of school-based health education than their heterosexual peers, even in states where sexual education was mandatory. So even in our red state here in Maryland, our young people may not be getting what they need. 8 states actually restrict having any discussion about anything that relates to LGBT plus issues at school. So, and they're shown here. And then there's variation by state for conversion or change therapy. Fortunately, in Maryland, we have a law that bans conversion therapy, but there are states where our youth may live in neighboring communities that it's not banned. So it's really important still to ask about experiences so we can provide and try to link them into appropriate care. Youth are diverse. So I am coming to the near of my presentation, and I hope that you have found this to be very helpful. I want you to walk away thinking and celebrating the diversity of youth. They may experience key vulnerabilities and contextual experiences that may predispose them to high outcomes of substance use, homelessness, marginalization. The list could go on and on. And it's the result of the spaces and the contextual experiences that they're often in. I think that by using an intersectionality approach and addressing things from a multi-level approach, we can incorporate this different aspects of who those youth are, as well as try to address interventions in a concrete way that makes sense for them. I think we have a role and we can do this. With this, I'll end and acknowledge my funders, my colleagues, and take any questions.
Oh, Renata, that was fantastic. You overuse a word that I use all the time. That was really great. I think just even from defining who youth are to all the different aspects and intersectionality, and then with the way forward as well. So really love that. There is one clarification question in the chat. Maybe we'll start there, and I have a question because I have the floor, and then we'll open it up. So one was from Tracy Addy, who asked when you put up the YRBS data, if you were speaking about actual intercourse, penis intercourse.
Yes, so the YRBS data looks at sex before the age of 13 as penetrative sex, and defines it as mostly, so they ask specifically penetrative sex, penile vaginal, but other types of sex as well. But it's focused on penetrative sex.
I think it brings about an important point, because there may be kids who are not engaging in actual penetrative intercourse, but are doing lots of other things that increase their risk, and making sure that we're counseling, asking, and then using the data they tell us and not assuming to help guide. So it's a really good question.
Yeah.
I did have one question to ask. You talked about the importance of engaging family and the protective effect of particularly embracing family, that they're non-stigmatizing, et cetera. Can you talk a little bit about the tension between that, engaging the family, and the autonomy of the adolescent, and maybe you can give some guidance on that?
Yeah, thank you for that. So here, as you know, as adolescents age, we do want them to have the ability to have one-on-one time with their provider. They're emerging in their identity. The part of adolescence is to become autonomous, right? So we want to afford them that space. And so one of the policies that we have is that we spend time one-on-one with every adolescent starting at the age of 13 years old. So really we have a posted policy in place in clinic that we're going to spend one-on-one time alone with the adolescent. And how do we do that without doing a parentectomy and we cutting off the parents, right? So we always talk about it from the framing of development, right? So this is an opportunity for your adolescent to have a chance to verbalize, to talk, to have a safe space where they can actually explore or discuss in a safe manner and get good health information. It's not a place where we're trying to get secrets, hide secrets, keep secrets from parents. And so really we outline with adolescents what's considered mandated reporting, what's not mandated reporting, and then actively come up with a plan to share back to the parent, to engage the parent in things that they feel is appropriate to share. So we're not sharing everything, right? But we do want to actually look at it as a shared partnership. Let's think about what we can share with your parent, because they're here, they're interested in supporting you. We see that we know that they are supportive, or they may not be supportive, right? So how do we engage them in that way? How do we try to help them to be more supportive? I hope that answers your question.
It does, and I just wonder if you can talk a little bit about, particularly, there's the under 18, but there's also the 18 to 24 age ranges in that youth, and how, technically we don't have to have those parents spaces, but how to bring those parents to the space, particularly if the adolescent or the young adult is fearful, et cetera. Maybe give the listeners some strategies on how to do that in a safe way.
Yeah, Yeah, so the dynamic for the young adult is different than the dynamic for the adolescent, right? So they may be in or out of the same shared space. They're becoming more autonomous, more independent. I think that you definitely have to approach it from their perspective. So in thinking about what do you think you need in order to be successful? And then thinking about from a if you're going to include, if they feel like their parent, or I think we should also think about how do we use the word parent loosely, right? So the family social support, it may not be a biological parent, right? It may not be a legal guardian for the younger, and it may not be a relative, right? It may be a peer, an older peer. It may be a gay father, a gay mother. It may be a larger social network, right? So just in thinking about who's that larger social network. And so thinking about what do you need to be successful, right? So when you think about your own success, right? We can't work independently, right? I'm not successful because I'm doing this all on my own. I often leverage you, right? I often work with you. So what do you need to be successful? And thinking about how can you try to ask or garner support without feeling dependent on those that larger social support, because it should be your building blocks, not necessarily that so coming from the bottom, not from the top. Because I think young adults feel like, oh well, it's just if I ask for support, that means I'm going to have to just be limited to what they say. And so really trying to go through a strategy, negotiating, role playing even. Let's talk about ways that you can do this so that, they have like an idea of methods before they leave.
Stop hogging questions. Please raise your hand or put in the chat if you have any questions. I'd love to open it up. I would love if you do have them to put your camera on so we could see you.
I do want to respond to Tracy's other comment. So that chart is from the Family Acceptance Project. And Caitlin Ryan's group has done a lot of work around family acceptance, really critical work in this area. And so their materials are available and free. So you just go online, you can download them, print them out. They will also send them to you. And I know that they've done work, they're in California, but they've done work specifically with organizations, religious organizations, family organizations, families, just about how to foster a place of acceptance, even if it doesn't align with your own beliefs, and do it in a way that is supportive of everyone.
Definitely, and I put in the chat, but I'll say it again. The recording of this talk is going to be available, as all your slides are going to be, and everybody who attended will get a link. Yes, go ahead, Tracy. You're on mute.
I just wanted to say thank you. I didn't mean to be anonymous in the chat, so thanks. That was awesome.
You're welcome. Thank you.
Others. It's so good, Renata. Maybe one of the things that you could potentially, you alluded to it, but maybe talk more explicitly. I think sometimes we talk so much about LGBTQ youth and that we think it's obvious that you'll know who's there. I wonder if you can talk a bit about eliciting that information from a young person who may feel stigmatized, ostracized, coming in and presenting that. Maybe you could talk a little bit about how to get that info.
Yeah, thank you. And I wish I could have included more into my talk, because certainly that's one area of passion of mine. Most of the data in this area has been done among adults. Let me just say that, right? So usually what the adult literature suggests is that we should ask sexual orientation, gender identity using two different methods. So sexual orientation, just specifically asking about one's sexual orientation, I find that when you're asking that question, it really depends on the age of the adolescent and the young adult, right? So as individuals age, their identity is going to be more secure. They're going to be able to articulate it easier. They may feel more comfortable sharing. So, what I often will start out with, is asking about attraction, right? So, and asking about who, when they are attracted to other people, who are they attracted to? And sometimes for the younger adolescent or teen, they might say, attraction, what do you mean? Like, well, what makes it feel good? Like what gets your heart rate going? What gets you nervous? Who gets you nervous? So it may be as simple as that, right? And then including questions around sexual behavior, dreams, fantasies, right? Who are you thinking about? I always ask about sexual behavior separate from relationships, because I find that often, because the concrete nature of adolescence, right? You'll often say, so, are you in a relationship? No. And then, and when was the last time you had sex? Yesterday. Okay, so that, so concretely, those are two different things, right? A relationship may be different than, who you're having sex with. They may not be the same person. So asking those questions and asking things differently in different ways. For older adolescents and young adults, I think you can specifically or more directly ask about one's sexual identity or sexual orientation. Do you identify as bi? Do you identify as gay or straight? Places are more often using like intake forms to actually assess that information. So intake forms are an acceptable strategy that actually has been demonstrated to be comfortable and very well received with adult populations. For gender identity, you really have to ask as a two-step if you're going to use a form, right? So what's your sex assigned at birth and how do you identify? You can't just put on, are you trans? Yes or no? Not appropriate. Hello. People don't know what that means, right? So really trying to keep those two separate. And, I will ask that question one-on-one, particularly for younger kids, right? We don't know from the literature because there hasn't really been great studies on this. This is one area I'm, interested in, is the best way to ask for the younger kids, right? So those emerging adolescents that are 10 years old, right? So, but I'll ask about, what's your journey? Tell me your gender journey. Tell me your who you see yourself as. When you look in the mirror, who do you see yourself as? And how's that different than what people tell you look like? How do you feel on the inside? Who do you see yourself as an inside, right? And how's that different from how you look on the outside? Is it different? Is it the same? Or I might ask about pronouns. What pronouns do you prefer for me to use? What pronouns do you use for yourself? Or what pronouns do you use when you go in that gaming module, right? And you log in, or what name are you using? Or are you using a different name? And just explore it in that way, because often what the younger adolescent is doing, they may actually have pronouns that they use for their peer group, right? Which are their preferred pronouns. And then they're not using those in other spaces because they don't feel accepted or affirmed, right? And so you want to try to give concrete examples in that instance so that you can get to that information.
Tracy, you have another question, I see. Go ahead.
I do, I'm full of questions.
No.
How much data is there available on risk for cisgender girls and young women who are attracted to women, or who are attracted to women and men who are lesbian or bisexual in their identity?
Yes, thank you. And recently started to look at this. So we, with the push study, actually had a group of about 100 cisgender and trans men who were assigned female sex at birth that were also enrolled. And Dr. Jim McCready's, one of our fellows, is looking at some of this data and really have found that one, I would say that a lot of the risks that we see in the population of assigned males who were transgender women or cisgender men, it is similar. So really high rates of substance use, condomless sex, STDs, even some exchange sex, not at the same level, but still present, and unstable housing. So really key areas, similar risks that occur. And so what she's also looking at is receipt of sexual and reproductive health services, and has found that really being out to your provider is really critical in receiving sexual and reproductive health services. So if, and what's interesting with that data is that there were, the lesbian youth were very out to their provider. The bisexual, these are cisgender females, were less out to their provider. And those that were questioning, that were engaging in sex with males and females, not out at all and not receiving any services. So that's a really critical area that we really will need to address where there's a need.
So now just to piggyback that, there was the Boston study is like several hundred young people, same gender loving females or cisgender. I always get mixed it up, but essentially higher rates of STIs, but also online sex, transsexual sex, and limited use of PrEP, but having sex with individuals that could expose them to HIV. And definitely in terms of sexual health education, no messaging, no discussion of this at all in schools. Oftentimes we think about, let's talk about LGBTQ. We oftentimes go straight to MSM and get the females having sex with females or males. So it's a really important point, Tracy. And I think increasing attention needs to be on this population who have risk.
Yes, thank you, Tracy, for bringing that up. I really appreciate that. And a shout out to Fiona Chirac, who's helping to lead those interviews.
We have about 2 minutes left. Any other questions? All right. I want to make one last comment and then thank you. I think the piece that I really wanted to highlight from what you did, Renata, and appreciate that you did, was to tie the intersectionality. We can't just deal with their HIV or their PrEP. We really, for youth, I think the piece is all of it matters, and taking the time to think about how that youth, all those pieces fit together, and on any given day, because they can change and how you see them because of the evolution. Thank you for a phenomenal talk. Really thank you for attention to your questions. Next month, Marina, who do we have coming next month to a webinar toolkits near you?
I haven't anything scheduled yet. We're still working on confirming.
Awesome. And while we do that, please, if you have something that you want to share, again, it's not just about our voices, it's about all of our voices. It's to engage and amplify. Please feel free to reach out to Marina, to myself, and say, hey, we have this great program or this idea that we'd love to talk about. And we, again, would love to amplify you. With that, we'll yield you a minute of your time back. Enjoy the day, enjoy the week. And again, thank you, Dr. Sanders, for a wonderful presentation.
Thank you.
Thank you.